So today we're looking at chapter 13, that is concepts of injury prevention in the sports performance book. There are a couple chapters afterwards, by the way, on like nutrition, but we don't do the nutrition chapters in this course anymore because you guys are literally going to need nutrition at the top of the year. And it doesn't really have any better or new information. So objectives today are to understand the frequency of injuries and what they are, how they happen, common risk factors, and then, how to decrease that injury risk. So obviously there's a lot of very specific injuries that are very problematic for athletes. An injury is bad for literally anyone, but it's especially bad for athletes considering that like their job is to perform in this, athletic category. And so this prevents you from being able to do that. This is kind of like, again, we were talking about the bro split versus like a, maybe a multi-day split yesterday. And we were laying out all these different examples and looking at things, right? Well, the best split, in my opinion, is like, the video was like, well, 2 days a week is most effective for growth. In my opinion, the best training split you've got is the training split that keeps you from getting injured. Because like, even if you were like getting really good results for 3 months because you had like this optimized, perfect training plan, but then it results in a little bit of like overtraining, and you end up getting hurt, and you have to take 6 weeks off, that's doing nothing, that's really going to slow you down. So this is another kind of classic example of like, people always ask me, they're like, should I do cardio first or should I do my strength training first? And it's like, what I tell people, I say the same thing every time. I'm like, well, physiologically, it's been shown that doing weightlifting first is better because it's more intense and you always want to do your intense stuff first. Like every workout you design should always go from intense to less intense, like that, downhill. That being said, if you are one of those people that likes to zone in by doing their cardio and like that's the first thing you like to get to and it's your way of like waking up or doing this or doing that, and you're just like, look, you prefer it, I want you to do the thing that you most prefer because I want you to come to the gym regularly. If you hate your workouts and you don't want to do them because you're not looking forward to them, I don't want you working out that way. So I will take the less physiologic sound workout and get a more consistent workout because I think that is always going to be better. So anyway, so there's a lot of very specific problems in athletics that are going to cause like a lot of injuries and stuff, several factors that can kind of result in these things. And so we need to have a very good program strategy for how to fix this, right? We need to know how to prevent injury. And, if we don't prevent injury and our client does get injured, well, then we need to know how to recondition them after they come back from that injury, right? So, we're going to just move up the kinetic chain. The way this PowerPoint works is it's just going to start at the bottom and work its way up. It's like, here's all the problems of the foot and ankle complex. So foot and ankle injuries, you're going to see things like Achilles tendonitis, plantar fasciitis, and the metatarsal stress fractures. So these are all pretty common. When we talk about these things, right, we're talking, Achilles tendonitis and plantar fasciitis are two sides of the same coin. Like if we look at, actually, I think are they on the next slide? Yeah, if we look at Achilles tendonitis, by definition, by the way, anytime you hear the word itis, guys, this is a principle that you should learn and just kind of keep in your brain. Anytime you see the word itis, it means it's an inflammatory problem. It's inflammation of, and then it's like wherever we're talking about, right? So like IT band syndrome, iliotibial band syndrome is what that's called. That's absolutely IT band tendonitis. You can get like runner's hip, which is where the TFL is rubbing. That's a tendonitis, and it's where it's inflammation in a tendon. Golfer's elbow, tennis elbow, both of those things. We'll see those in a little bit. Those are lateral and medial. We call them epicondylitis. Itis, inflammation of a tendon. Itis is inflammation. Tendinitis is inflammation of a tendon. Okay, so that tendon is connective tissue, right? And it has to run near like bony landmarks. So if we look at like Achilles tendonitis, for instance, you know, you look at your Achilles tendon, it's where your soleus and your gastrocnemius, like they come down and they become, you know, this tendon here that has to kind of grab the back of your heel, right? And so this has to wrap around like this. If this gets really like tight and starts rubbing, look at your heel bone here. Let me find a better picture of the bone with the hook. So here's your heel bone here. Look at this hook. Right? Like that's pretty intense. I mean, what's great about that is that it allows a muscle to get really good grip here. You know, this is a projection or a process, right? So that's great, right? That's a really good little process there for grip, but the muscle has to run here and around this bone here, right? And then there's another one here. Sometimes you'll get people who describe like getting a sort of a stabbing sensation at their heel, like a burning sensation there. And that is your plantar fasciitis. So your Achilles tendon wraps underneath the foot and becomes your plantar fascia, which is this webbing on the bottom of your foot, right? And so we can see it there, right? We can see it there, right? And you'll hear people say they're like, they get pain. It feels like, they'll say it feels like stabbing. Feels like they're getting stabbed on the bottom of the foot, like right here. And that is because they kind of are. I mean, like, you know, this little hook right here is kind of stabbing them, you know. Like, same thing is true of like somebody with Achilles tendonitis. Achilles tendonitis, it feels like somebody people will just, you know, it feels like, you know, when you're at the grocery store and you get hit with the little like bar like on your Achilles and you're like, ah, right? Like that's the worst feeling, but that's it kind of feels like that, but you know, all day. So those problems both suck. You know, has anybody in here ever had plantar fascia? I'm going to be asking injury questions a lot today. Anybody in here had plantar fasciitis?
I have.
Yeah, because you're the half marathon guy.
It's not pleasant, especially when you're running and it's affecting you during the actual half marathon. Yeah. You just hit the pavement and you just feel that pain, that stabbing as you're hitting the pavement.
Yep, I believe it. So obviously that's not great, right? And here's the thing, right? Like it does kind of go away after a little while, right? Like you start walking around, like it's really bad when you wake up in the morning, first couple steps out of bed. Then it kind of loosens up and it's fine for a little while. And then every time you sit down, every time you rest, it kind of tightens up again. And then if you just kind of consistently do something over like a really long distance, well, then it just starts hurting in general. So not awesome. Same thing is true of Achilles tendonitis. It's worse in the morning because like basically you got to think of it as like your muscles had all night to kind of do their own thing. And now suddenly you're causing them to kind of have to, you know, stretch and relax and, you know, heat up and stuff. And you kind of need to get them to do that. So how do we fix this, right? Oh, wait, actually. And then one other problem that we're going to see a lot of is metatarsal. We'll see stress fractures. Anybody ever had a stress fracture in their foot? Nobody? That's good. I'm going to be asking a lot today, but I am hoping for no's all day. Anybody had this injury? I'm hoping for a lot of no's. So you're going to see a metatarsal stress fracture is often where basically there is going to be generally it's going to be the second and the fifth metatarsal are where we usually see a lot of these problems, like right in here and right in here, right? Those are sort of the two most common that we'll see. And basically this just happens because of like a really rigid foot, like a foot that just doesn't have enough flexibility. And so like, because it's not very flexible, you know, rather than like running relatively soft, it's like boom, 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 boom. You know, I always think of it as like, you think whenever I think of like someone who has like, and you'll see it, by the way, you do a LESS test. Remember the landing error scoring test where they do the depth jump? You do that and you notice that somebody's like, wham, and they're like landing really hard. It's like, oh man, you walk like Frankenstein. you know, like, and like that sounds, you know, kind of weird, but what I mean by that is like, think about Frankenstein, right? Like, what does he always do? He's got his arms out the side like this, right? And he kind of walks really stiff, right? And the way, like, you know, the way that you do portray that if you're trying to walk really stiff, right, is you land on your heel and you go, you know, like boom, 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 you know, he's got those big old, you know, Frankenstein shoes. Unless you're watching Young Frankenstein, in which case he's got tap shoes on. For anybody. So yeah, so that really rigid foot causes a lot of stress, you know, a lot of stress. So something's got to give, and unfortunately, it's your bones. So how do we fix it? How do we fix, you know, this problem, right? Well, we're going to need to work on the proper extensibility, particularly of calf muscles, right? So we need to work on our mobility there and stretch all that out. We need to strengthen the appropriate muscles as well. That's going to be your anterior tibialis and your toe flexors. It's also going to be your posterior tibialis as well, right? Like we need to work on both of those tibialis muscles. So when we talk about like working on the, oh, hold on one second, guys. My deepest apologies. My girlfriend is leaving for the airport. So if we're looking at, why is Jillian Michaels all over my YouTube feed? What happened? So we need to strengthen that posterior tibialis. So best ways to strengthen the anterior tibialis, you know, is to use like a resistance. Is to use like a resistance band, right? Like a really gentle resistance band. And you're basically just going to pull straight up because the anterior tib does dorsiflexion, right? It, you know, it's in charge of pulling your toes towards you. Most people are not very good at like strengthening this muscle. This muscle gets very, very weak because a lot of us have elevated heels. We spend most of our day in plantar flexion. So this dorsiflexion muscle gets lengthened and it gets used to staying in that lengthened position rather than being, you know, properly strong. So you take a resistance band, whatever like level you can, tie it around the bottom of the foot, and you're basically just going to pull straight back like this. Now, he let that down really slowly because he's showing you a bad rep. You're going to come down slowly. Sorry, he let that down very quickly because that was a bad rep. So you want to go up, pause, and then nice and slow on the way back, right? 4-2-1 tempo. 1, 1, 2, 1, 2, 3, 4. 1, 1, 2, 1, 2, 3, 4 with that dorsiflexion. Now your posterior tibialis is also really important to strengthen. That one is a slight ankle inverter, right? And so we're going to do the exact same thing. We're going to use a little resistance band here. And it's going to be really simple like this. Now, I saw a little bit of a tibia turn there. Ideally, you don't want to have too much tibia turn there. I like this version. This is pretty good. If you're doing it by yourself, this works excellent. But you can see the angles pulling up here like this. I much prefer, and like it works. You'll see physical therapists will give this as homework all the time. I don't hate it. I don't hate it, but I don't love it either. This, if you are training your client, is a much better way to do this. So you get them on like a bench, or, you know, they can do it seated actually just fine. And then what you're going to do is you're going to grab that band and you're going to pull down. And you're also going to, and obviously out to the side as well. So you're going off to the side and down. And that way they have to actually, now they can actually like scoop while they're doing this, right? So you can go from like a dorsiflex position into a slightly plantar flexed and inverted position and then scoop back. So you're going to scoop like this. That's a little bit better. And you just need, like, if you're on the floor, you can't do any of the scooping action. You can just move sideways. Still very valuable, by the way. So it's like if you're assigning homework to your client, have them do the seated version where they just kind of come inwards. But if you're training your client, like make them do the scoop. And Mo's big on that distinction. He'll walk you through like some really good tips for how to place that band. But that is basically how we're going to strengthen the foot, right? So if you've got like a really weak foot that has really struggled with plantar fasciitis, and here's what's really frustrating about all the itises. What sucks about all of them is like you need to do some PT, you need to do some physical therapy exercises to fix them, unless they are currently flaring up. If you are currently in the middle of like a bad flare up where the inflammation's going crazy, all the therapy in the world, like that's like, you know, would somebody say it's my Rolfer friend said this, it's like trying to pet a cat that's already mad at you. Like it's never going to work, you know. Like, the cat doesn't want anything to do with you. You need to let it calm down and come back later, and then it'll relax and, you know, let go. So that's we don't want to do that, right? We want to make sure that if it's in the middle of a flare, we're kind of letting it just relax and get sort of de-inflamed, uninflamed, and then get it to then work on all the therapy for it. So next one we're going to see is ankle sprains. There's a lot of different types of ankle sprains. One that we're going to see the most common is going to be the lateral ankle sprain. That's this one right here. Lateral ankle sprains are usually, you know, going to happen like a lot of times where an athlete will be running and they'll basically roll their ankle. Right, they'll do this. That's the you know, you hear people say that all the time. It's like, oh, I rolled my ankle. They don't say they sprained their ankle. It's like, oh, I sprained your ankle. You know, like that's what a roll is. And what's happening here is this little connective tissue that attaches your fibula, this bone right here, to your talus, which is this bone that lives on top of your heel bone. That's your, remember, your calcaneus is your heel bone, right here. And then your talus is this little navigator bone that lives on top of it, like right here. So your fibula being attached to your calcaneus or your fibula being attached to your talus, either of those ligaments getting torn is a lateral ankle sprain. So that's also one of the reasons why it's the most common in sports, is because like it kind of has two causes. So obviously that's going to increase its chances. But very, very, very high re-injury rate here. You know, very, very common. And it causes a lot of time lost in athletes and stuff. And so risk factors here, what we're looking for to see if somebody's going to deal with this is if they've had a history of sprains. Obviously, that's going to be the first thing, because again, it's a nagging injury that likes to come back. It's going to be the shoes that they're wearing, and poor balance is key here. People with poor balance, right? Think about when you're walking, you just lose your balance a little bit. You often will just turn your foot at the last second to kind of make up for things. Now, if you're really tight and you go to invert, but you are not used to inverting, well, then you're going to sprain those ligaments, right? So this is one of the reasons why overpronation of the foot is such a big deal, right? So if the lateral ankle sprain is rolling the foot this way, why did that happen, right? Well, it's because like this is ankle what? Inversion, right? This is ankle inversion, whereas most of the time we see people who pronate, which means that we see a lot of people who are ankle everters, right? We see all those people with flattened feet, right? Look at this. All right, look at this person here, right? Like they are pronating like crazy. They are showing the bottom of their foot towards the midline. Right? So like that is putting them in a position, if we look at like ankle eversion, where we're seeing, oh, actually, these are actually pictures of sprains here. But we're seeing where someone does too much inversion, right? So if you spent all day in eversion, right? If you spent all day like this, in this posture, which a lot of people do, right? Flat feet, right? Overpronation, right? These ligaments here on the outside, they start to get really, really tight because like they're never getting stretched out. They're in a shortened position all day long. And then one day you roll your ankle the wrong way, and suddenly this thing that never stretches has to deal with stretching and flexibility, and all of a sudden it tears. Now, we will sometimes see medial ankle sprains as well. That'll happen on the opposite side of the foot. you'll see this ligament on the inside of the foot get torn. This is not as common. I love the name for this, by the way. It's your deltoid ligament. But like, yeah, so you'll see like lateral ankle sprains, you'll see medial ankle sprains, right? And that one's, also not good, but it is not as common for two reasons. Number one, people's knees don't usually like fall that way when they're spraining something or like losing their balance. And number two, like most people overpronate. So those are actually pretty flexible on that side. They're actually in a pretty good spot there. And then lastly, we got high ankle sprains, which are ugly. Lateral ankle sprains are definitely the most common. High ankle sprains, I would argue, are the most detrimental. So there's gonna be two of these. There's gonna be this one, which is not quite the one. Like this is attaching your tibia to your fibula, right? If we look at like, we were looking at all these ligaments, right? There we go. That's the good one. You can see here, there's the one that attaches your fibula to your talus. And by the way, there's this band, that's your nervous system is able to actually communicate right underneath this band here. And so when that gets tight, that's where sometimes people get tingling in those outer two toes there. But this runs all the way down and is responsible working with your peroneals and stuff. But you can see here, right? Fibula attached, but then look, your tibia and your fibula are also attached to one another. And there is also this membrane in between those two bones that holds them together. There's this fascia that kind of wraps between those two bones. And that membrane, that fascia that's in there, it's really important to not overstretch it. When you detach the ligament that is holding those two bones together, what ends up happening is your fibula starts to slide down and away. So a lot of times they'll have to go in there and put pins in your ankle in order to like re-staple them back together. My nephew had to have that done. So that is ankle, that's what we're seeing there. So those are our most common ankle injuries, right? And how do you get how do you get like a high ankle sprain? Oftentimes, the best, easiest way to get this injury is to wear like a really tight boot that kind of forces you into dorsiflexion, like a boot that kind of forces you to have like a specific shape, and then like, externally rotate, and then basically just pops that membrane and pulls those two bones apart. Not great, right? So if you're wearing like a really rigid boot while you're also trying to like, move laterally, I don't know, pretty risky. So how the heck do we work on this, right? If we're trying to work on preventing this, or if we're working on coming back from this, right? Again, we're going to ensure proper range of motion of the foot and ankle complex, right? So we kind of go, like I said, we're going to see proper extensibility show up on pretty much every solution today. So we got to look at the overactive muscles. We need to look at the underactive muscles. So overactive muscles here are going to be things like your peroneals group. Remember, that's the muscles. Those are the muscles that are running along the side of the foot there, right? So they run here, and then they grab the top of the foot, and they cause ankle eversion, right? So your everter muscles are often overactive. So we need to work on that. Honestly, easiest stretch for that, guys, it's kind of lazy looking, but it's like my favorite for it, is literally just to go right here, take a step forward, drop this leg across your body, and then drag your foot just like this. That's a really good peroneal stretch. So see what I'm doing with my foot there? Hold on to something to balance. But that's a really good stretch to work on that proper extensibility. But again, this is the biggest problem that a lot of people make. They'll work on the stretches all day. They'll stretch and they'll stretch and they'll stretch. And they're like, I don't know why my injury is not going away. I don't know why I'm not getting more flexible. And it's like, you're only addressing one side of the problem. You got to flip to the other side of the joint. You need to do strengthening exercises. In fact, we are finding, guys, that the strengthening exercises are honestly more important than the stretches. We're finding more and more and more in the research about that every single day. Like they're actually, a lot of people don't even prescribe to the Rice method. While we're talking about injuries today, If you've ever heard the RICE method, it means rest, ice, compress, elevate, RICE. That is what you're supposed to do when somebody gets injured. Sprain your ankle. First things first, get off the ankle, rest it, ice it, compress it, elevate it, right? Get it above your heart. It's not bad. And like, that's something we've been doing for years now, but now they're finding that like icing is really preventing healing from occurring fast enough. It can be great for the aches of it and the pain of it, but it doesn't necessarily like make it heal any faster. So we don't love that. And we're finding that like we need activity. So we're looking, you know, nowadays they're incorporating is it meat? Yeah. The new one is yeah, it's meat. Which is down here: movement, exercise, analgesics, and then treatment. So taking like, you know, to get moving, you know, do a little bit of light exercise, taking anti-inflammatories that you need to take, and then, you know, do your treatment through like more exercise. Russ. So that is, and I'm not saying like prescribe that, you know, necessarily, but we are finding movement is more important. So again, somebody's got really tight muscles, right? Okay, awesome. We need to loosen those muscles up. On the flip side of that, we also need to strengthen those underactive muscles. So for foot and ankle stuff, we need to have proper dorsiflexion. How are we going to do that? Strengthen the anterior tibialis, strengthen the posterior tibialis. Both of those are going to be big again, right? We want to work on balance exercises for the foot. Learning how to balance and stabilize is going to be absolutely key here. And then strengthening of your dorsiflexors and your inverters. Yeah, that's actually totally what I said here. So yeah, working on the tibialis muscles. All right, so that's the foot and ankle complex. Then we're going to move up the kinetic chain and take a look at the knee. We're going to see a lot of injuries here: ACL tears, patellofemoral pain, runner's knee, and meniscus tears are going to probably be the most common. So when we are looking at the epidemiology here, first one we've got is what's called patellofemoral pain. This is basically where somebody will have aches and pains literally on the kneecap. So your patella is your kneecap, right? And so if you feel like a grinding sensation with your patella and your knee there, that's patellofemoral pain. Now, for the record, this says dislocation. This is a picture of a dislocation, but this is kind of what's happening and causing that patellofemoral pain. The patella is designed to slide up the quadricep like this, okay? You can see this little ridge here. If we look at it like, you know, from below, it's meant to slide up that ridge. This bone is meant to move this way and back down. But remember, all of your quadriceps muscles, actually, there we go, are coming in from different angles, right? There's your vastus lateralis, that's on the lateral side. Your vastus medialis on the medial side. Your vastus intermedius is underneath this one right here. That's an interdigital. And then you get your rectus femoris, which is this one here that runs all the way down and grabs right here. Kind of makes it look like it stops here and then picks up here again, which is kind of true, but for the most part, it actually kind of goes straight over top of it like this. So this is your rectus femoris muscle. So your patella is designed to like move underneath all those muscles, but it is touching those muscles. So if one muscle gets really tight, what's going to happen is this isn't going to slide straight up and down. It's going to get pulled to the left, or it's going to get pulled to the right, which is where we'll look at if there's always the same picture and I love it. Patellofemoral tracking. We call it it's like, is it tracking in the right direction? You'll see this, right? It's either getting pulled laterally or medially or even, you know, inferiorly or superiorly. It gets pulled in all those directions, and it can go, for the record, it can totally go at diagonals as well. And that's also really bad. Like, but this bone is supposed to slide. And if it doesn't slide properly, actually, there we go. Look at that. There's a good tracking. There is way too much medial tracking, right? So that's what causes our injury here, right? We just see way too much tightness in those quadricep muscles that's pulling our patella in the wrong sort of direction there, right? So that's a really big one. We're also going to see tears. We're going to see like ACL tears is going to be a big one, right? So in your knee, you've got basically 4 main ligaments here, right? Actually, that's great. You can see you've got your ACL, that's your anterior cruciate ligament. You get your PCL, that's your posterior cruciate ligament. So they make an X, right? And then you see the kneecap is missing here. They've removed it so you can see it. So the ACL is in the front, that's anterior. The PCL is in the back, posterior. Cruciate in both those. What that means is it comes from the word meaning crucifix, which is, a cross, right? So they cross one another, and then they're ligaments, right? So the front cross ligament and the back cross ligament, right? ACL, PCL. Then you've also got your LCL, that's your lateral collateral ligament. And then you've got your medial collateral ligament. And that's attaching your femur to your fibula, and this one's attaching your femur to your tibia. It's creating stability on the side. So if we pull up, and you guys will have to forgive me, I'm no artist, but if you think about like your femur coming down, I'm just going to draw it like a dog bone, right? You think about your tibia coming up, and it has this like kind of, platform that it kind of sits on there, right? And then your fibula is down here, right? And it kind of runs down like that, right? So now there's your knee, and then normally your patella would be right here, and it's going to track and go up this way, right? But we'll get rid of that. So your ACL ligament is the one that's in front, which means your posterior ligament's the one that's in the back, right? So the posterior ligament here, we'll draw that one in red. Your PCL creates stability by going like this, right? So that's the PCL. And then your anterior ligament goes in front of that. We'll draw that one in green. So that one's in front, right? And they make a cross from one another, right? And so that's the ACL. And then you've got your lateral collateral ligament on the lateral part of the leg, right? That's over here. That's your LCL. Lateral. And then you get your medial collateral ligament on the medial side. That's over here. That's your MCL. So that is creating all that stability in the knee. And that's sort of like the order that they are sort of arranged in, right? Going from here to here, going from here to here, making the cross, and then the outside collateral, dealing with like lateral motions and stuff. Now your knee is meant to primarily hinge. It's meant to go back and forth like this. It is not meant to move side to side. They can do a little twisting, like we can twist at the bottom portion here, like this and like this, right? But what we can't do is we cannot move laterally like that and that. That does not happen, or at least, it's not supposed to happen. Because if it does, right, imagine this kind of tilting like that. You would have a huge gap here, and that's going to tear this ligament, right? Or if you go this way, you're going to have a huge gap here, and that's going to tear this ligament. Now, this one's not very common. You don't often tear the MCL, mostly because, like, how many people do you know get tackled on the inside thigh without hitting the outside other leg on the, the other leg kind of protects your, so it doesn't happen very often, but it could, maybe like in like MMA or something like that. Somebody gets kicked just from the bottom perfectly. They miss the first leg, come straight in like through the legs. Yeah, that'll maybe happen. So what's that?
I sprained it one time, MCL.
Your MCL? Huh, yeah, not quite as common. Yeah. How'd you do it?
Fell off of like a jump snowboarding, and then landed on my ass, and then my board like slammed to the ground, and then I just jerked it and just sprained.
Fair enough. Yeah, that'll happen. That I guess makes a little bit more sense because you're strapped to the board, so I could see that pulling on that inner side. Luckily, I mean, You don't want any of these injuries. But luckily, both LCL and MCL tears are relatively easy to fix because they're pretty exposed. You know, they're right there on like the outside of the body, so they can get in there arthroscopically and fix it pretty easily. Did you have to have surgery?
No, I was just a sprain. Like I was probably better in like a month, but I felt it for like a year or two.
Yeah, sure. That's good. It was only like a partial sprain. One thing that they don't talk about in the book, but the way sprains work, guys, is we give them grades. So you have like grade 1, grade 2, a grade, you know, normal ligament here, right? The grade 1 tear is just like overstretched, which is probably what happened. Or you maybe had like a grade 2 tear that didn't require surgery. But like a complete rupture is where it's like, ugh, we got to reattach this, you know? Do you remember the other night when I was talking about like that extra ligament that some people have in their forearm? We were meeting up a couple weeks ago. Sometimes when you tear something really severely, because that ligament really doesn't do anything, doctors will go in there and surgically remove it and use it somewhere else in your body, which is so cool, you know? But they'll use it as sort of like spare parts. So that is all of the like, so that's ACL tears, MCL tears. There's also runner's knee. You'll see that one. Runner's knee is where you'll get like a rubbing sensation on the outside of the knee. This is much more commonly referred to as IT band syndrome. But it's basically where you'll get aches and pains on this rubbing sensation out here, right? So the IT band is kind of burning, and that can cause like pain in the actual knee itself. You also sometimes get jumper's knee. Jumper's knee is very common amongst like basketball players. They'll get pain right at the bottom of the kneecap, right? So your kneecap just below it is getting a lot of pain. That's from really tight quadriceps muscles. And that's where that rectus femoris is rubbing on the patella there. So how the heck do we get that patellofemoral pain? Well, like I already talked about, it's poor patellar tracking, right? If that kneecap doesn't move up the way it's supposed to, right, you're going to get like, you know, the bone, this bone's going to grind on your femur, right? Your patella is going to grind. That's not great. We also see ACL injuries, which, by the way, up to 75% of them are non-contact. You guys heard me say this before, but like I always say, non-contact injuries, you know what that means? It means an injury that should have never happened. That means you just got hurt living a normal life, right? Now, obviously, it could be like, okay, well, I fell off a roof, you know, like, you know, but like an ACL injury, right? And that's the most common, by the way, like of the you know, CL injuries. It's this one right here is the big one that happens all the time. That ACL, right, this thing right here, basically gets turned because like this bone either, you know, rotates and pulls and overstretches it, right? And that's exactly what we're trying to avoid. So when you see somebody land with like a really straight leg, that'll sometimes tear it because it'll try to twist as it's already in a very extended position, or it'll happen while people are trying to like make a really strong plant and then cut, because like a cut is often like very lateral and very transverse, right? So if I like juke this way and then I turn really strong, right, I'm turning as I'm pushing off. That's overstretching that ligament, and you'll sometimes see that will cause an ACL tear. So what are our risk factors? What kind of leads to the poor patellar tracking? Well, we talked about that as tight quadriceps muscles. What leads to ACL, MCL, or LCL tears, or MCL tears, or PCL tears? Well, that's going to be excessive knee valgus for the ACL injuries. If you've got a client who have their knees cave in, right, that's increasing the Q angle. So right here, right, creating like a gap. So the ligament's already stretched out. So then when you try to cut, you're way overstretching it. And so it tears, right? Meanwhile, this ligament over here is getting used to being shortened. So the LCL is also really commonly torn. So knees caving in, which is a very common postural distortion that we see, often causes injuries in the ACL and the LCL, both of those lateral ligaments. The PCL It's not as commonly torn. It's really thick for one reason, and then also like you have to like fully hyperextend the knee. It's just a very difficult angle. And then MCL, not as common as well, although obviously it can still happen if this goes this way. But generally what happens, people get tackled from the side, people twist too much, they get kicked from the outside coming inwards, right? And that causes tears in here and in here. So how do we fix it? How do we stop it from happening? Well, we need to, oh, and actually I gotta, is meniscus tears up here? I don't have meniscus tears up here, but let's talk about meniscus tears. So meniscus tears are kind of unique. What your meniscus are is they're these little discs that kind of go like this. They get really close and they kind of come down. And what that does is that increases how deep of a like cave there is, right? So it's really wide up here. It's really wide up here, and then it gets more narrow as it comes down. So there are these little discs that live on top of your tibia, and they're C-shaped, right? So from the front here, you can't really see this, but they're both shaped kind of like this. And the other one's right here. You know, to continue our talk on snowboarding, these are kind of like half pipes. Their job is to keep everything, you know, inside this area rather than like this bone sliding off that way or sliding off that way, which is, you know, exactly what we are trying to avoid. So that is the knee valgus, right? That's you know, that can cause that, right? Your meniscus can slide because maybe you have excessive knee valgus, or knee varus. That can also be really bad. People who are bow-legged, the knee varus, right? They often experience, they're the ones who might get a PCL injury or might get an MCL injury, right? So there's a couple different ways that your meniscus will tear, by the way. There's a couple different versions of it out there. Yeah, you'll sometimes see little vertical tears here, right? Radial tear. Or you'll hear what's called a bucket handle tear, which is this right here. It makes it look like you've turned your meniscus into the handle of a bucket. You'll sometimes see flap tears. This is really, this one is like, you got to like injure it without going all the way down to the bone. Anyway, I don't know why that one's called a parrot beak tear. I guess it kind of looks like a parrot, but I don't know. But anyway, these are, you know, all the various different types of tears that you can experience. And it happens because, you know, you put way too much pressure. A lot of times you land really hard on your meniscus while you're twisting, and it's literally, it creates like a shear tear, right? You're pushing in and then twisting, and that causes separation. So those are all the ligaments of the knee, and all the very common knee injuries, right? So how do we fix it? How do we stop this from happening? Again, weight-bearing exercise, really good for strengthening your hip and your quad region. We need to work on proper range of motion and stabilization of the knee. We need to make sure that none of the muscles are pulling the toe in the wrong direction. None of the muscles are pulling the leg in the wrong direction, right? We need to correct our faulty movement patterns, stop squatting with the knees caving in, right? And then perform plenty of like stabilization and balance exercise and work on strengthening the lumbopelvic hip complex. So again, it's going to come down to your overactive, underactive muscles. If we look at the overhead solutions table again here, honestly, if we see someone's knees cave in, knees move inwards, right? Tight adductors, tight hamstrings, tight TFL, right? Weak glutes. Well, then we need to do adductor stretches. We need to do hamstring stretches. We do TFL stretches. And then for strengthening, we need to do things like lateral tube walking or a ball squat with abduction, which is this right here. You squat with the ball. That's a hip thrust with abduction, which is also really good, but right? Actually, she's okay. So she's just doing abduction. That's not a hip thrust, but she could go into a hip thrust and then do that, right? Make it a two-part movement. You can do a ball squat. You can actually have the band around the thighs as you squat down and then push outwards, right? And you can see she's going into inversion with her ankles too. It's great. That's abduction. That's what we want. There's also adduction going this way. If you have a client who's like knock-kneed, not knock-kneed, you have a client who's bow-legged, they would go this way. That's adduction, right? It's the knees caving outwards. So a lot of abduction movement is what we need to work on to strengthen those glute muscles, and a lot of hip extension to strengthen those glute muscles. Speaking of glutes, let's go into the lumbopelvic hip complex. So next one we're going to see low back injuries. Holy crap, we have a lot of low back injuries. About 80% of humans will have chronic low back pain, meaning it lasts at least 6 weeks or longer, oftentimes for years at a time. And so low back injuries are our most common general injury that everybody deals with. Lateral ankle sprains, most common sports related injury. The reason I'm pointing that out, I'm pretty sure that's one of your homework questions tonight. It's like, what is the most common sports related injury? Lateral ankle sprains. Most common injury that humans deal with, aside from athletes, low back pain. Everybody gets low back pain, but there's so many different types. Generally, we're talking about either disc injuries, it's a herniation, a slip, a tear, they're all the same thing. Muscle strains, literally just, spasm of muscle in your back, or SI joint pain, sacroiliac pain. So disc injuries first. When we look at this, what is happening, these are all your spinal discs, right? Each of your individual vertebrae. Let's look at the vertebrae by itself, right? Let's look at these bones here. So there's all the bones, right? This is the thoracic vertebrae. There's your lumbar vertebrae. Actually, here we go. Cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral vertebrae, or just known as your sacrum, and then coccyx, which is not spelled right. This must be from some other, it must be like a British way of spelling or something. They all kind of look like this for the most part. This is actually, where'd that one go? Love that picture. So here's kind of examples here, right? The cervical vertebrae, they're kind of special looking. They're a little smaller, but generally they look like this, right? There's this kind of area for a disc to sit. And then these like processes here for muscles to grab. So you can create like twisting actions, and then like your spinal column can run up through this tube. This bone is built around your spinal column, right? So when you hear about somebody who broke their back, here we go. Anybody ever broke their back? Oh, come on. I got one yes in this room right now. Mirror. Maybe you stepped away. Very common injuries here is spinal injury. Uncommon injuries is breaking your freaking back. Luckily, if you don't sever this tube here, it's not going to cause too many problems. You can come back from that. But so what is a slipped disc? What is a herniated disc, right? Well, your discs are these soft little squishy membranes that live, actually that's great, there's on top of your spine, right? So each of these like little bits in between each vertebrae have this squishy little sac with this really thick wall here, and then this nuclear material inside of it. It's like squishy material inside of it. That squishy material is known as your nuclear pupulsus. And this right here is your annulus. It's this little membrane that's meant to kind of, it's like this little water balloon with a really thick wall. Now, if you compress your spine and twist it simultaneously, or if you bend really strong laterally, and this hard bone tissue tears this wall, what will happen is the nuclear material will start leaking out. Now, look here, right? We looked at the disc a second ago. We looked at the spinal disc by itself. Should get this open. Well, look at this. This is an empty tube when we're just looking at the bone all by itself, right? Your spinal cord runs through that tube. That's where your spinal cord is. This is that's your central nervous system right here, right? So it's running through, and then all of the individual nerves that branch off, right? All those peripheral nerves are the ones that are branching out away from there. So when we look at we look at this, there's the central, that's the spinal cord, and then every nerve branches off from there, right? So there, it would run through the tube and then branch off like this, right? Well, it's supposed to go here. If you leak that material out and it starts pinching between this hard bone tissue and the nerve is caught in the middle, it's going to cause aches and pains. And that's why herniated discs feel so bad. And that's why this is called a herniation, by the way. I am not going to Google hernia because it is horrifying to look at. But what a hernia is in the body, any version of a hernia, is it's where you are tearing the lining of something and something else is leaking through. So like, you know, picture, well, don't picture it too intensely, but like a friggin' horror movie where someone gets like cut and their guts start spilling out, like they've herniated their entire abdomen, which is actually what can happen. You can get what's called an abdominal hernia, where you tear your abdomen wall through your abs and literally stuff starts leaking through, which is why we are not looking up a picture of it because it is awful. Do not Google hernia. It also usually happens close to the groin, which is, that's actually what you're getting tested for. If you guys remember going in for like a physical, the turn your head and cough, right? When you cough, you contract your abdomen. Your doctor was basically checking to see if you were at risk for a hernia. An abdominal hernia. This is a herniated disc. So whenever you tear the lining of something and something else starts leaking through, that's a herniation. So when this material is pinching that nerve, it causes aches and pains. That is a disc injury. So a slipped disc, a herniated disc, a torn disc, whatever they want to call it, they're all basically the same thing. We are also going to see muscle strains in the low back and abdomen, you know, weak core muscles, weak stabilizer muscles. Oftentimes you'll get like a back spasm because of all these muscles here called your transversospinalis muscles. They're all the little itty bitty tiny muscles that are meant to kind of keep everything, you know, held together, and they create stability. They run all the way up. If you look at your multifidus, your multifidi, because they are technically, actually, there we go. That's what we're looking for. Look at all these little tiny muscles, right? Like there are a lot of itty bitty tiny muscles here, right? So when you excessively move your spine in one direction and cause like pain, because like this muscle's like, you pulled it, you tore it, it's starting to pull. Well, now it's pulling on your freaking discs. And that's going to cause like your nervous system to get poked. Anytime you touch your nervous system, it's going to cause pain up or down. And that's why that's really, really, really quite painful. Muscle spasms are very, very common. And then we are also going to see sacroiliac dysfunction. So your SI joint is actually, this is kind of fun. This is a non-synovial joint. This is not, there's not a joint cavity here. This is supposed to not move very much, but it is supposed to move a little. And you can get aches and pains in your low back if this is too rigid or if it's not mobile enough. Too far in either direction is bad. If it's really flexible, maybe not in a good spot. If it's not flexible at all, you're also not in a good spot. And so that will cause radiating leg pain a lot of times. You'll either get pain in like the groin area if it's too tight, or you'll get pain in the low back area if it's too loose. So oftentimes what we need to do is strengthen the area around here. Now, this is not a muscle. This is actually fascia. It actually looks more like this with all this webbing here. It's a terrible picture. There we go. Looks more like this. There's a bunch of webbing back here. So that's like fascia. These are ligaments, right? That are kind of holding everything together. But there is a lot of low back musculature that comes down here. If you look at like your thoracolumbar fascia, all this stuff, right, coming down, that's creating stability around your sacrum there, right? That low back area needs stability. So if you pull too much in one direction, a lot of times also you'll need to either strengthen or loosen, depending on what the problem is, your quadratus lumborum or your QL muscles. These are the muscles that are attaching your bottom rib to your pelvis. And it allows you to do, you know, this motion. the side to side stuff. Never thought I'd be doing that on camera. So that's your that's your quadratus lumborum, or your QL, as we'll often call it. If that gets really loose on one side and really tight on another, because maybe you sit on your wallet all day, it creates a lateral shift that can create a scoliosis, right? If you see like someone who, both of these are, here's in a neutral position where, they're pulling the way they're supposed to, they're creating stability, right? But if this one pulls up because maybe they're sitting on their wallet over here all day and not over here, if they kick, remember, David, we talked about this, kicking one leg under one side of the neck creates elevation.
Mm-hmm.
Right? This is now getting really tight, and this one over here is getting really loose, right?
Yeah.
So it either pulls the pelvis up or it can pull the spine down. That can also happen. It manifests itself kind of depending on how you hold your posture.
Right.
But that will cause like radiating back pain just along the entire area there. And that is where you'll see people, look at this, they'll do these really deep, intense stretch where they grab the freaking client and they just pull that, like they're like their body's up here, right? And they're just pulling their pelvis down below something. If you ever go to a chiropractor and they do like a hip drop on you, it's literally, it looks like the friggin' what is it from wrestling, the people's elbow. Like, a chiropractor will literally drop themselves and try to like take your spine from being in this position. They'll pull it all the way over here so that it'll hopefully land back to neutral. You'll often see people who have what is called a list. They will be listing from one side to the other when they have this type of problem, right? So if they've got one really tight QL, they will list. And so they'll stand kind of like this and they'll walk, and it looks like they're literally shifted off to the side. So they need to get back to neutral, right? I had a list when I popped my sacrum out of place playing Ultimate. I got hit by a guy really hard. And it was a mistake, but like he was just both running and he just hit me like here and like knocked me over to the side. Now, if my spine had stabilized properly, I would have been able to hold that position, but instead I listed like this. I didn't even notice it. I just felt really achy and painful, and it was awful. And then one day I was like noticing in the mirror, I had this like big gap on this side and like no gap over here. And so I was scoliosing. And so the treatment for that is actually to go up to a wall and then take a towel, wrap it under your elbow, tuck it between here. So that creates like distance from you and the wall. And then it's literally, you're just going to try to push your your hip in towards the wall there. And basically what you're doing is you are holding this top part of your spine in place and moving the bottom part below it. So you're trying to take your spine from being twisted like this to being, you push it like that, hoping that it will, get back into alignment. So that one's not very common. That's not even in your book. But that is a very common injury. I like to talk about that one because it just goes to show you how important it is to stack the spine properly. So we'll see muscle sprains, we'll see ligament sprains. Again, this happens when there's lack of stabilization, right? Again, we talk about the spine, right? A lot, and we talk about like exercise, we talk about movement. So many people think that exercise is it's just about movement. It's about squats, about running, it's about moving, it's about moving, right? Movement is life. I agree with a lot of that, but I would argue that exercise is just as much about moving as it is about not moving. It is just important to know how to stabilize and not move as it is to actually move through a full deep range of motion. Both are important, right? So proper extensibility in the overactive muscles is really important here. We need to loosen those up. If you have an excessive anterior pelvic tilt, right, that's tight muscles in the low back, right? And proper strengthening of the underactive muscles. So the muscles in the core on the opposite side of the joint need to be strengthened. So we need to work on proper neuromuscular control and core stabilization. So we need to work on that local stabilization system, the transverse abdominis in the front, the multifidus in the back, the internal obliques on both sides, the diaphragm up top, the pelvic floor muscles on the bottom. And there's that box, right? We need mobility in our overactive muscles. We need to stretch those out if we need to, and we need to strengthen any underactive muscles that we're working on. That could be glute muscles most of the time, core muscles most of the time. It could be any of those. And then lastly, we've got shoulder pain. Lots of different types of shoulder pain. We're going to see shoulder impingement is a really common one. Impingement, by the way, means impingement, honestly, because it is where the soft tissue of the shoulder is being pinched by the hard tissue of the bones, right? So the picture I pull up every time, right? So you can see this is your supraspinatus muscle. It's superior to the spine of the scapula. When you look at your scapula, it's your shoulder blade, right? So we look at this. This ridge right here is known as the spine. The supraspinatus lives right here on top, runs across and grabs, and it's in charge of helping with this. Now, your medial deltoid does most of the heavy lifting, but your supraspinatus is there to help. If it can't, though, right? If this is running and it gets pinched between all this hard tissue, well, then you're going to have aches and pains. You're going to feel like a clicking or a grinding when you are doing like shoulder raises, right? Any range of motion where you feel that like clicking or grinding sensation, you are on the, and if you ever get like really bad pain, you know, that's shoulder impingement. We will also sometimes see the much more severe shoulder dislocation or subplexion. Oh, that sucks. Where you will actually see like the bone basically be moved out of the joint. Right, there we go. So a couple different versions of this. You'll see anterior dislocations. You'll see posterior dislocations. You'll see subplexions, which is where basically it just moves straight out of the joint, like inferiorly. So it basically just falls downwards like this. Not so great. Very, 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 very painful. So normally, you know, your humerus is supposed to sit in this little cavity here underneath this hook right here and behind this little ridge right here. It's supposed to sit in this little, you know, it looks really similar to your hips actually, right? If we look at the hips, you know, there's a little socket right here, this little hip socket, because it's a ball and socket joint, right? Just like your shoulder. So you have what's called your glenoid cavity. Ooh, I love that picture. That's kind of cool. Which is this right here. And then your humerus is supposed to sit inside of that. It's supposed to sit in that little socket there. So that allows you to move through the range of motion. Now, that's really great. This is the most mobile joint in your body, by the way. It's got the most space in the joint, therefore it's the most mobile. That's awesome until we consider that with increased mobility comes decreased stability, right? So something that can move a lot is awesome, but it's also not very stable. Again, I just said it, I'll say it again. Sometimes it's not about, you know, shoulder movement. Sometimes about shoulder stabilization. It's not always about movement. Sometimes it's about anti-movement. So how do we, you know, address these problems? Like when we see shoulder impingement, which often, by the way, comes from just repetitive motions. You're doing the same thing all day, you know, working at a desk, right? It's going to cause shoulder impingement eventually. And then shoulder instability, right? Poor conditioning, traumatic mechanisms that are happening there. Where, you know, you're not stabilizing properly and all of a sudden you get hit and your shoulder pops out of joint. That can happen. I gently I mean, not gently, but I dislocated my shoulder when I was a high schooler. I was unloading groceries and I was screwing around, throwing a can of soup up into the air. and I threw it up as I walked under the roof, and it landed in the gutter. And I was like, oh. So I like climbed up on some trash cans and then climbed up on the roof and then grabbed it, and then the gutter broke. And I fell off the roof and like, dislocated my shoulder. It was an expensive hospital visit. It was like at a time when my parents did not have insurance. They were not happy with me. It was like in a little like small gap. It was bad. Anyway, so that that's a shoulder dislocation. Again, it's just a lot of working on stability, and it kind of goes right back into place eventually, as long as you don't break your collarbone or any other problems. The big thing here, though, is we need to work on anti-movement, right? We need proper extensibility, yes, but we also need to strengthen our upper back musculature to stabilize and hold our shoulders in place. So we do corrective exercise. We work on, if you get shoulder rounding, we're going to stretch out the pecs so we can get the shoulders back. You got really bad, internal rotation. Well, we're going to work on that external rotation. We're going to do external rotation swings. We're going to work on loosening up those lat muscles, right? And that's oftentimes when you're working on it's the external rotators that are often the weakest, right? We need to do more of this and less of this. That is what we're looking for there. So that is sort of a brief rundown of the most common injuries that you're going to run into when we are working with like athletes and stuff. Any questions on any of that, guys? How are y'all feeling?
Feeling good, feeling good.
Love that.
I have a question, Brad, because I've seen people, because when I was doing yoga, I took a yoga therapy class. And we were talking about, for like people who would do down dog, a lot of them would use the flexibility. They would use their shoulders versus bending at the back.
Oh, okay. Yeah.
So a lot of people were trying to get into a deeper position, and a lot of teachers would allow that. And I've seen that happen with like strength training too, where they're like having them do stuff where they're having them.
You see this kind of thing.
Yeah. So it should be more of her back than her shoulders.
Yes. I mean, for the record, this is actually really good shoulder mobility to be able to go that far posteriorly. That's actually very mobile. But yes, you should be, when your arms are overhead like that, your arms are getting into what we call a closed pack position, where it's basically like bone on bone. And so what you actually want to do is you want to oftentimes create like a lot of stability by pushing through the arms. I think she's killing it actually, and bending more at the hips, right? So she's pushing through the floor and up. Yeah, that's what you want to do, because what that does, that draws, rather than getting like up here like this. In fact, we look back at that first lady.
I've even seen some trainers when they're actually doing like shoulder presses, like they have them like they've seen them like they're cueing them, but like the weight is more closer to behind the arms and kind of being back versus kind of like in a more upward position.
Yeah, so you do not want to do like, so to use an analogy exercise here. You ever see people do like a barbell press behind the head?
Yeah.
You'll see that sometimes. So again, that puts you in a closed pack position of your shoulder. Not quite what we are looking for here. It's not the pictures I want. My God, I thought that first briefest of seconds, I thought that was a picture of me. I wear exactly that outfit all the time. I was like, let's see here, behind neck shoulder press. So the problem with this exercise in general, Arnold loved it, he was big on it, is that it puts you into this, like I said, like a closed pack shoulder position, which if you've got the shoulder mobility can be okay, but most people don't. And what ends up happening when you press like that is these little pins that are at the, like on your cervical spine, and then also like right in that acromial arch right there, all start grinding on one another, like bone on bone contact. So yeah, that's not a super awesome way to do it. You'll see the same thing, Joseph, when you see people do like downward dog like push-ups or decline push-ups. They're more commonly referred to as pike push-ups. It's the most common name for them, where you'll see people do this. This is a really good pike push-up. He's killing it because he's got where he's his elbows are kind of going off to the side. I can't pause this. It's a gift. You can see like his shoulders going down, and it looks like it'd be the same angle if you were doing like a shoulder press, right? Versus, let's see if we can find someone doing a not so great version. I mean, he's also, this isn't so great, but for a different reason. He's elevating his shoulders, which you don't really want to do. Yeah. Oh, actually, yeah, that's terrible. Similar, the angle's good, like his elbows are traveling back, but look at how like he's up here like this the whole time. And he's literally moving through a range of motion like that. That's not ideal. This, he's got a relaxed shoulder when he's doing it. Not seeing quite what I'm looking for with the hands. A lot of people are not doing, no, that still really goes well. I'm not quite sure we're gonna find what we're looking for, but you will see that. You will see where people will get all the way back there. We do not want that. It basically causes grinding. It causes bone on bone contact, which is what we want to avoid. Same thing with the down dog.
And then what do you do for people who have constant shoulder dislocation? Like I used to have a chiropractor who like his shoulder would constantly get dislocated to the point where he knew how to just pop it back into place. Like he would literally go in front of people and just like pop it back in.
So when that happens, that is often someone who had like surgically repaired. They have increased range of motion. They're kind of stuck with it. They need to work on stability for the rest of their life. And it will help a little. But yeah, that's just going to be something that happens.
I remember one day he was like working on someone and all of a sudden you just see like his arms just dangling.
Yeah.
And the patient got freaked out. So then he just let him pop it back into place himself.
Yeah. So here's what your shoulder ligaments look like. It surrounds the whole thing, unless you pull it out of the socket and you tear all of this. And then I can find a good picture of it. I probably won't be able to find it. Yeah, okay, you can kind of see this, right? So you tear this stuff here, right? So then you bring in like all this here. So you put it back into place and a lot of it repairs, but it's got little holes in it, you know, like it doesn't quite repair the way it's supposed to. So now you got all this increased mobility, which is great, you know, but not any stability where it won't stay in place when it's supposed to. It's funny where it's kind of like when you break something in your house, you know, or something that you own. You know, you break it once and it's like, well, then it just re-breaks all the time, you know. But that's kind of the mechanism that's happening there. Your doctor could get an elective surgery and put a bunch of extra stuff in there, but it causes a lot of scar tissue and and most people want the mobility more than they want the stability, if that makes sense.
Yeah, it was just funny to watch him. He'll just be like nothing happened, just like pop it back in, like it was just like a normal everyday occurrence.
Horrifying. All right. So we're gonna do something kind of fun here. I want to take you guys through and show you how to plug everything in. Since normally we get to do this when we practice in person. Normally I sit everybody down and like have you plug in exercises, get used to picking sets and reps and things like that. But since tomorrow we're doing a special like go around and run around and sprint around and stuff. Actually, that reminds me, let me check the weather. Yeah, it's gonna be you know, clearish skies tomorrow, guys. Only slightly overcast. We're in a good spot. Since we're meeting up tomorrow and doing that, we're not going to get a little practice at like picking things. I want you know, Edwin and Joseph, I want you guys to start getting a little bit more familiar with how to use the big chart and all the numbers and stuff. I kind of want to go through 3 examples here. So let's say we got a football player, right? We got a football player who, you know, when we think about like football, and they're going to skate the line between like hypertrophy and max strength. They want to be strong and powerful, but they also want to be like big, and they need tissue, right? They need to be heavy enough to not get pushed around on the field. So, is that what I want? Nope. Hold on a second. Where did that full freaking year go that I pulled up yesterday? Is it in here? Annual plan. All right. So we're gonna make a football player here. So I'm gonna clear all this. Although this is gonna stay the same. So clearing all this as well. Sorry, I can't just do this with this click of one button. There's month 2. We're gonna build 3 months worth of workouts here. Oh, what the heck? Stupid thing. And then we'll get into examples in individual workouts after this. So let's just put this, I think we can get away with that. Okay. So here's our annual plan first. We got a football player, which means that throughout the year, we need to make sure, in fact, actually, if you look in your sports book, you'll see an example in there. Let's pull that up actually. Oh, did I not put it in here? Where did I put it? Ah, of course, yeah. Actually, it's right here. All right, so we're gonna pull up this book and we're gonna steal Nassim's idea for stuff. So we're gonna go to the Science of Periodization chapter here. Oh wait, no, we're not. No, we're not. No, we're not. These are our examples, but no, we're gonna go to the appendix. All right, so they got programs for baseball players. They got programs for basketball, I think is next. Basketball players. They got programs for football players. Soccer, I think soccer is next, actually. Scrolling. Oh, I missed it. Football players. Okay, so here's our football player, right? So let's take a look at like what a good season would look like for a football player. So what they care a lot about, and this is, you know, they're gonna work through all of these different phases. 1 into 2 into 3 into 4 into 5, and they're staying in 5 in like May and June, and then it's like preseason and in-season training starts, and that's where, you know, for preseason, you're just focused on corrective exercise. That's really, you know, our main focus there, right? We're working on corrective exercise so that we can create like stability and hold our client like together, right? So take a look here at like preseason, you know, stability, and then you're probably doing a little bit of power training as well to like keep your athleticism. But look at like what in-season training looks like. September, October, November, December, right? It's corrective, it's stabilization, it's strength endurance. It's all the really gentle stuff because we don't want our workouts to take away from our athletic, you know, actual training and stuff. So that's 5 phases of friggin' training there for an overall athlete, which is not as specific as I'd like. Also, that's a lot of workouts to have to create today in the next 23 minutes. So what we're going to do is we're going to take our client from stabilization into hypertrophy into power. So they're going to get stable, big, and powerful, right? Because strength, hypertrophy, and we'll just stay on the low end range when we get to designing our workouts. And we're just going to go back into hypertrophy, back into power. That's a good 1, 2, 3, 4, 5 months of training. We'll go back to stabilization. In fact, actually, we'll go back to hypertrophy one more time, and then we will reset into stabilization. So 1, 3, 5, 3, 5, 3, and then the cycle would reset in January, back in stabilization. So here's a general, working our way through the OPT model. This is very linear periodization here. I'm not doing, you know, 1, 3, and 5 all in one month. I'm just having a theme each month. I got a stabilization theme, I got a strength theme, where I'm really focused on like hypertrophy training, And I've got a power theme where I'm really focused on the maximal power. When it comes to cardio, I've got stage 1, stage 2, and stage 3. So now in January, I'm going to be doing, so let's look at these first 3 months here. So this is January, but also it would, you know, it'd apply to other months as well. But let's look at January first. We're going to look at our 3 months here. I would lay out the full year if I had to, but for now I'm just creating the 3 months, right? So I'm working on stabilization. February, I'm going to work on hypertrophy. So we're going to change this and say hypertrophy. And in March, I'm going to work on power. Okay. And we're going to do a 3-day split in January, a 3-day split in February, and, or I'm sorry, a 4-day split in February, and a 3-day split in March, which means I'm going to create a very simple stabilization routine, a 4-day split here, and a 3-day split here. We're going to create a bunch of different workouts today. So on the 3-day split, what I'm going to focus on is I'm going to set this up. This is corrective exercise, right? This is where my client is really working on their endurance. They're working on stabilizing. So what I'm going to do is I'm going to keep it really simple, and I'm going to create a total body workout that they're going to do every single time. They'll probably have specific SAQ workouts on their off days for cardio and things like that. So I'm literally going to create a 1-day split that they do 3 times a week. So it's just workout A, and workout A. They do it for 4 weeks, right? Now, I like this. It works pretty well. I would probably, if it were me, want a little bit of variety. So I'd probably have like workout B situation there. And then next week they would switch. So it'd be BAB, ABA, BAB, right? And that way they kind of go back and forth. In fact, actually, no, I'm not gonna do it. So we're gonna do this sort of like very introductory basic version here. For month 2, I'm gonna do this 4-day split. We're gonna go workout A, workout B, back to workout A, back to workout B. So that's gonna be like an upper day and a lower day, or maybe chest and back, and then shoulders and legs, right? And then over here, we'll go workout A, workout B, and workout C. Meanwhile, for our cardio, we go back to January. We're only doing stage 1. So that's really simple, right? We're just going to do stage 1 on Tuesdays, Thursdays, and Saturdays. Now for month 2, I'm in strength endurance, or I'm in hypertrophy. So I'm going to do a blend of having like a stage 1 day and a stage 2 day. So bouncing back and forth Wednesday and Saturday, stage 1, stage 2, stage 1, stage 2. And then I've got all 3 stages. This is our maximal intensity stuff, right? So I got a stage 1 day in the beginning of the week, a stage 2 day in the middle of the week, and a stage 3 day of sprints on the 3rd day. That's probably a lot of sports specific stuff there. Okay, so now I've got sort of like my 3-month example here. I've got my annual plan laid out. Now, let's take a look at what that looks like and plug all of this in. This is my month, right? Let's plug this into the actual week here. So like I said, it's going to be Monday, Wednesday, and Friday. I'm doing workout A, and I'm in phase 1 here, right? This is stabilization. So I'm not even worrying about these 3 or these 4 other ones. So then I got cardio, stage 1 cardio on Tuesdays, Thursdays, and Saturdays. Sunday's a rest day. I'm literally just going to copy this, and he's going to do the same thing every week for 4 weeks, the entire month of January. Okay, does that make sense to everybody so far? Am I moving too fast, or is this pretty clear?
Yeah, I got a question.
Yeah, please.
When they're training multiple phases like this, you know, if they're doing something less intense like corrective exercise and stuff, can you, like, if people work out twice a day, can you mix it up with, like, you know, like stabilization in the morning and then, you know, afternoon workout more intense? Or
yeah, absolutely. If they're doing 2 a days, which is common in football. You're not going to run into that in most people. That's a very sports specific thing. When you are working out that much, you know, are probably working with a professional team that is like, or high schoolers who are basically injury proof because they're young. But like you've got like a nutritionist who's helping, you've got like a sleep recovery person, you know, you got like all these, you're focused so much on recovery and corrective exercise, you know. But yeah, you can do that. So there we go. We got January piece of cake, right? This is our stabilization routine. So now we look at February. We're doing that strength endurance, or we're doing hypertrophy. Sorry. So we got workout A. That's going to be on Mondays. We got workout B. That's going to be on Tuesdays. We are going to repeat that on Thursday and Friday. We got a stage 1 cardio day on Wednesday and a stage 2 cardio day on Saturday. We got rest on Sundays, right? And we're just going to keep it. Oop, and this is in the wrong row. This is going to be phase 3, right? Because it's hypertrophy. So phase 3. Kept it really simple there, right? So that's February. That's hypertrophy. Then we got our client in power. So we go back to this whole, you know, ABC situation here, right? And that's for phase 5. So I've got workout A, workout B, and workout C. We're going to go Monday, Wednesday, Friday. We're going to do stage 1, stage 2, stage 3, and then a rest. And that's all in the 5th phase of training. So there's my year-long example, right? For someone who's trying to get big and powerful, big and strong, right? All right, so now we got to build actual workouts that are going to correspond with this. So we reference our annual plan, and it's like okay, it's January 1st. I got to write my client's program, right? So what I'm going to do is I'm going to look to see, okay, what am I doing? I'm in January, right? And I said I was going to do A every time. So it's going to be a total body routine focused on stabilization. So I open up my OPT template here, and you know, I'm gonna go ahead and delete that actually. What's my client's name, guys? Somebody give me a name for this person. Give me a funny name.
Brad.
No. Every time.
Gunther.
Billy.
What is it, Dion?
I said Billy.
Billy. All right. You know what? I like it. All right. So here's Billy. He is our football player, right? So he wants to increase hypertrophy and power. Right? He wants to be big and powerful. We'll say hypertrophy, strength, and power, right? So this first month is just going to put him in phase 1. Nothing fancy there, right? So this is going to be January 1st, 2022. So let's say Billy's got, let's see here. We look at our overhead squat solutions table. His problems are he's let's go with an arms fall forward guy and an anterior pelvic tilt guy. He's a low back arch guy and an arms fall forward guy. Those are his 2 problems, right? So we are going to SMR. We need to loosen up his hip flexors. I have this set up to the right size. Hold on. Right, so we're going to SMR his hip flexors. We're going to SMR his erector spinae. And we're going to SMR his lats, okay? And then on our coaching tips, remember we never use a foam roller on the erector spinae, so we're going to say for erector spinae, use lacrosse ball off of spine. So we're going to have him do one set of that, 30 seconds each. Then we're going to follow that up. This is a stabilization routine. So I need to follow all of my stabilization rules here, right? So I'm picking SMR. Actually, what am I doing? I can zoom in more. If I put this over here. I'm going to pick SMR, and I'm going to pick static stretches for 1 to 3 sets, 30 seconds each on the reps. So let's go with a static kneeling hip flexor stretch. You'll find that in your books. A static spinal twist erector spinae stretch, and a static wall lat stretch, and a static pectoral wall stretch. Every one of those is going to be in your book. Now you'll notice that this one didn't have an SMR. Yeah, we don't really SMR the pec minor. We can though. Right, I could say SMR pec minor as well, and then say for erector spinae and pec minor, use a lacrosse ball. Right, and now suddenly I talked about like, all right, so there's our pec minor stretch. He's going to do this one right here. It's a pectoral wall stretch. I guess it looks like Daniel Craig. And then I'm going to do a lacrosse ball SMR pec. He's going to place that lacrosse ball right there in the pec minor area, right? So there we go. There's my routine, right? One set of each. And then again, I look at my rules. It's like it has to be 30 seconds hold for each rep. Cool. Piece of cake. Moving on to the next part. I need to get a little bit of cardio before he's like fully warmed up. So he's an athlete, he's a football player, you know, a lot of quad stuff. I'm going to do a spin bike. One set, 5 minutes, 50 to 60% heart rate max. So I'm not going crazy here. This is meant to be his warm-up, right? It's not zone 1, which is 65 to 75. It's below zone 1. It's just a warm-up, just getting his blood pumping. Now, for my exercise selection, I need to pick a core stabilization, a balance stabilization, and a reactive stabilization exercise. So for my core stabilization, of course, I'm going to go with the plank, right? That's going to be exactly the opposite of the hip flex or the erector spinae. It's on the front side of the abdomen, focused on stability. I'm not doing prone cobra, which would make the problem worse. So I go with the plank, I go with the side plank, right? And that's going to have to be for each one. Then I'm going to do a balance exercise. Let's go with a single leg lift and chop, right? So the balanced leg does not move. And then I need a reactive stabilization exercise. Let's go with a box jump to stabilization. So now let's look at my rules here. So I picked a core stabilization, a balance stabilization, and a plyometric stabilization exercise. I need to pick somewhere between 1 and 4 sets, 1 and 3 sets, and 1 and 3 sets here. So let's go 3 sets for everything. I need to pick 12 to 20 reps or an isometric tempo for my core stabilization, 12 to 20 reps or 6 to 10 single-sided, which this is a single-sided exercise. Obviously, I can't think of a single balance exercise that isn't, by the way. I don't know why they even have that listed. And then 5 to 8 reps for plyometric. So I'm going to go with 30 seconds each. Let's go with 6 each. And let's go with 8. My tempo is going to be isometric for these two. And I look at my tempo. It's supposed to be slow, and it's supposed to be a 3 to 5 second hold on landing. So we're going to say slow, 3 to 5 second hold on landing. Now I'm going to do this as a circuit, 0 seconds of rest between each of those until they get to the end, and I can choose 0 to 90 seconds of rest. So at the end, we'll go with 60 seconds of rest. Cool. Now, throw them on the speed ladder. You know, actually, I'm going to leave that off, and we'll do that as on our cardio days. So we'll leave that alone for today. It's not going to be part of the workout in the traditional sense. For my resistance training, I'm going to pick a total body exercise. We're going to go with a ball, squat, curl to press. Okay, ball, squat, curl to press, really great total body exercise. Glutes, quads, hamstrings, biceps, shoulders, and triceps. Total body movement. Love it. Right at the top of my circuit here. Then let's go with the stability ball chest press. That's a very unstable chest exercise. Let's go with a stability. Actually, you know what? Let's go with a kneeling cable row. So a kneeling row where we're working on that scapular retraction, which my client needs because they got rounded shoulders and arms falling forward. Let's go with a single leg shoulder press. Right. Then we're going to go into, let's get a little bit of more leg work in there. Single leg Romanian deadlift. So getting the back of the hamstrings going a little bit there. Single leg biceps curl, single, and actually stability ball skull pressures. So now you'll notice every exercise I picked was very unstable. These are all stabilization exercises for my total body, chest, back, shoulders, legs, biceps, triceps. And that way this circuit will work very well for focusing on stability. This person can still lift relatively heavy, but for the most part, I'm going to keep it. I look at my rules here. I need to pick somewhere between 1 and 3 sets of 12 to 20 reps. So I'm just going to keep it really simple. 3 sets of everything, 12 reps there. Right, except for this one, which is double side exercise, so 12 each. And then my tempo is going to be slow. And then I'm actually I could just write slow the whole time, but I'm going to write 4, 2, 1, because I'm really trying to drive the point home. And I want it to be a slow ease. And we're doing that because those are the rules. 4, 2, 1 tempo. So I'm going to do that because I'm really trying to drive the point home that I want it to look like this. 1, 2, 3, 4, 1, 2, 1. Right? So that is going to create that stability. That's going to be that athletic style of training. You see that very popular. Again, this guy's pretty controversial. I'm not a huge fan, but I do think that he comes up with some very creative exercises, and he works with a lot of freaking pro football players. There's Young Hoku and stuff, and there's a quarterback. Who's this? Oh, Taylor Heineke, right? So there's a very unstable leg exercise, right? And it's also a little bit of arms there, right? So you're doing this really unstable, it's loaded on one side with a band, right? Very good squat version, right? So that's a corrective exercise squat there. I will say he's not pausing much. Well, he does. Yeah, no, that's kind of a 4, 2, 1 tempo. He's just also coming up kind of slow. So stabilization routine, right? 50 to 70% 1 rep max. I'd probably list whatever that is for my client. 0 to 90 seconds of rest here. So let's go with, let's do this as a circuit, right? 0 seconds of rest here, there. And then give him 90 seconds of rest in between sets. For my cool down, I would cool down by stretching everything that I worked, but we're going to keep it kind of simple. We're going to ease him out by doing a little bit of cardio, and then we are going to repeat all that corrective exercise. And that is the program for the first month. He's just going to do that all 3 days. So I'm going to save that, right, as a stabilization routine, big, strong, and so that is sort of our football players' first month. Joseph and Edwin, does that make sense?
Yeah, so all of that is 1 day of a workout.
That's all 1 day. Right. Now for his cardio day, I'd probably be doing, something that looks like this. So this is, oh, and actually I should have listed this up here. This is going to be workout A. Right. And then I'll create the same thing. I'm just going to use this template here. and put this down a page. And then this is going to be stage 1 cardio. Okay, so for a stage 1 cardio, I warm them up the same way. Keep that exactly the same. I'm not doing core balance and reactive. I'm not doing resistance training, right? But I will probably do a little bit of actual, cardiovascular work here. So I'm going to say cardiovascular conditioning, and I'm just going to delete the stuff I'm not using, right? So for cardiovascular, and I should put these in different order. This is going to go up here. Okay, I don't quite know how to do this. So he's going to do SAQ first, then cardiovascular conditioning. So for my SAQ choices, 1 to 2 sets, 2 to 3 reps at a moderate tempo, exercises that involve limited horizontal inertia and limited unpredictability. So I'm going to go with speed, ladder, 1-ins, 2-ins, and then let's go with an icky, and actually that's probably fine. So speed ladder 1-ins plus 2-ins. So he's going to do a big long speed ladder. He goes 1 in and then 2 in. That's 1 rep, right? So he does 1 lap is 1 rep. He's going to do 2 to 3 reps. So we're going to say 3 reps there for 2 sets. And his tempo should be fast, but not super explosive. So we're going to say moderate. Okay. And then we'll give him 60 seconds of rest at the end of it. Then let's pair that up with a speed ladder. Let's go icky shuffle plus ollie shuffle. I will teach you what these are tomorrow, but icky shuffle is like side to side. Ollie shuffle is side to side like this. It'll make sense tomorrow, I promise. And then we'll give that 60 seconds of rest. And then let's go with like a left test. Or actually, you know what? Let's just focus on acceleration drill. 40-yard sprint, obviously important for a football player. 3 sets, 1 rep there. 60 seconds of rest. And then we will do a full field, 300-yard suicide. 3 sets, 1 rep for sure. That's going to take a while in 60 seconds. That honestly will feel like cardio because that's not 300 yards. That's, what is it? Yeah, whatever. It's a lot of yards. I don't need to do this. The yards permeable. And then let's just have, we're going to throw them on the treadmill. 1 set, obviously. There is no repetitions here. So we're just going to delete that. Actually, that's what I should have done. I should have been this. Treadmill for 1 set. Duration, we'll say 20 minutes. And this is stage 1, so 65 to 75% heart rate max. So there's our cardio day. We threw all the SAQ stuff there. And that's our first month of training. God, I'm already at time. God dang it. All right. So let's take a look at our next one. Let's take a look at month 2 here, right? So this is going to be phase 3, right? So this is gonna be phase 3 of the OPT. We are moving from stabilization into hypertrophy. So we're moving into this phase, but you'll notice the strength stuff would be the same if you were in strength endurance or max strength. So you go over here, we got our workout A. We're gonna say that this is chest and back day, right? So I'm just gonna go ahead and very simply keep working on this same stuff here, except instead of doing static stretches, look at my rules, I have to choose active isolated stretches for 1 to 2 sets of 5 to 10 reps, hold each rep for 1 to 2 seconds. So I'm going to change that to an active kneeling hip flexor stretch, an active spinal twist, an active ball lat stretch, and an active pectoral wall stretch. Let's go with 2 sets for everything this time. And the SMR gets to stay the same. Let's go with 2 sets of everything this time. And duration is going to be 1 to 2 second hold each rep. And that's going to be 10 reps each side. So there we go. Now it's 1 to 2 second holds, 10 reps each, 2 sets of that. Going to be pretty freaking warm by the time we're done with it. We go back over here. I need to choose a core strength, balance strength, and plyometric strength exercise. So here's what's kind of fun. This is going to be kind of cool. So I'm going to go with a stability ball crunch, which is going to be a full body movement a full core movement through a full range of motion using the entire core there. And then I'm going to pair that with a stability ball oblique crunch. Those will go very well together. I need a balance exercise. Remember last month we did that single leg Romanian deadlift as a leg stabilization movement. Today, I'm going to use it as a balance strength movement. Exercises can live in multiple categories. So we'll do a single leg Romanian deadlift. Last month, it was part of his workout. Now it's part of his movement prep. And then we are going to do a repeat squat jumps, right? So moving through a full range of motion. So I went from not moving my spine in my first month to moving my spine through a full range of motion. I went from not moving my balanced leg to moving my balanced leg. I went from not moving after I landed to repeatedly landing. So I look at my rules. I need 2 to 3 sets of 8 to 12 reps at a medium tempo. 2 to 3 sets, 8 to 12 reps, medium tempo. 2 to 3 sets, 8 to 10 reps, repeating tempo. So for the sake of simplicity, 3 sets of everything. We're going to keep it simple. 10, 10 each, 10 each, 10. Keeping it really simple there. Medium, 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 repeating. 0 seconds of rest each time. 60 seconds of rest at the end. So that's a pretty good core routine to get me nice and warm before the actual workout starts. So there's that. SAQ, I'm going to skip because we're going to do that on our cardio day. Now, resistance training. This is workout 1. So workout A of, A and B. So I'm going to do like chest, shoulder. Let's go like chest and shoulders, right? So we're going to do a bench press. We'll pair that with a military press. Then we're going into an incline chest press. Let's go with a dumbbell lateral raise. And we're going to we look at our hypertrophy rules. Right, so I'm picking strength exercises, 3 to 5 sets of 6 to 12 reps. Now, this is a football player. We're trying to get this kind of similar. It's like 75 to 85% intensity. We're going to kind of try to get this to similar to a max strength routine. So we're going to kind of skate the line here. We're going to do like 6 reps, 5 sets of 6 reps for this first exercise. So 5 sets here, 5 sets there. Let's go with 4 sets here and 4 sets there. And we're going to go with 6, 6. We'll do 8 to 10 here. So our tempo is going to be medium for all of these. Oh, wait. Sorry, I don't need to write medium. I'm going to write 202. 202. And now here's the thing about the hypertrophy side of things. I'm only supposed to take 60 seconds of rest. Okay, so that's relatively low rest when you're at 6 repetitions. I don't think it pairs up very well. I would prefer 90 seconds, but I am going to keep this textbook today. So we're just going to put 60 here. Okay. Yeah, I'm just going to move you guys over here so I can still see you. Be a little smaller. So that's our shoulder day, right? And then cool down, I can just keep all the same static stretches because the workout's over. I don't need to avoid, static stretching once my workout's done. So now I'm just going to copy this whole thing, put it down here, and do workout B. Right? So for workout B, we'll keep the same warm up. Those are still our same overactive muscles, but we'll change up how we do our core stuff, right? Rather than a stability ball crunch, let's do like a hanging leg raise. And then we'll do like a hanging oblique raise. Instead of a single leg Romanian deadlift, we'll do a single leg step up to balance, right? That'll still balance very much, move the balance leg through a full range of motion. And then instead of repeat squat jumps, let's go with split lunges, right? That'll be kind of explosive, which would be nice. And then we can keep all this other stuff the same. We have a real symmetry between our workouts here, which is kind of nice. Now, what we need is a leg exercise. So we're going to go barbell squat. We need a back exercise. So we'll go bent. Actually, we'll go weighted pull-ups. These are really heavy. You know what? No, we're not. We'll go bent over barbell row. Over here, we'll do a deadlift. And over here, we'll do the weighted pull-ups. Okay. And honestly, I get to keep all this the same too. So that was really easy to make, right? Now, remember, they're going to do this workout twice a week, right? Like they're going to do, so we look at our total volume here. I got 5 sets for my chest and then another 4 sets. So that's 9 on Monday. And I'm going to do it again on Thursday. So that's 18 sets, which is right where we want for growth. And then here's what I'm going to do when it comes to my cardio, right? So I go to my cardio routine here. And this is going to be stage 2 cardio now. Because I'm in phase 3. Keep the warm up the same. For my stage 1 day, actually, you know what? Stage 1 day in phase 3, I'm going to keep the same routine, right? I'm literally not going to change this up. This is what they do on Tuesdays. But then I've got my Thursday workout here. There's my Thursday workout. This is my stage 2 routine here in phase 3. So now I'm going to focus more on getting some of that agility stuff into my SAQ. So I'm going to go speed ladders to kind of warm things up. And then I'm going to go with a box drill. I'm going to do with a T drill. Okay. So for my box drill, look at my rules here. What am I supposed to do? I'm supposed to pick 3 to 4 sets of 3 to 5 reps. Let's go by 3 by 3. So 3 sets of 3 reps, 3 sets of 3 reps. And then my tempo is going to shift to a fast tempo. There we go. Now, because this is a stage 2 routine, I need to do intervals. So what I'm going to do is I'm going to be on the treadmill for both of these exercises, obviously. And I only want to do like 20 minutes of cardio here, right? So I'm going to do, let's say 1 minute in stage 2, in zone 2. So that's going to be 76 to 85% heart rate max. And I'm going to recover for 3 minutes in zone 1. So 65 to 75%. 5 sets of each of those. It's going to take 4 minutes. 4 times 5, that's 20 minutes of cardio right there. Does that make sense, everybody? That's our hypertrophy routine. Everybody clear on that? Edwin? Sorry, you unmuted for a second.
Yeah, good to go.
Okay. But that all, like, that's all tracking as a routine. Not moving too quick?
No, you're fine.
Okay. Because I know I am moving quick. So this is our hypertrophy routine. All right, let's look at power. So now we are in phase 5. We got workout A, we're gonna have workout B, we're gonna have workout C this time, right? So for phase 5, now I can actually get rid of the spin bike here, because guess what? We're gonna do dynamic stretches. I'm still gonna SMR all those same things, right? But this time I'm gonna do a walking lunge with a twist. That's a really good stretch for my hip flexor. I'm gonna go with standing spinal twists. So literally side to side like this, right? Or you know what I could do? I could do a stability. This will be fun, actually. Yeah, we'll do a medicine ball lift and chop. Wait a minute, that was a balance. That was a balance stabilization exercise. Again, yes, but now it's a dynamic stretch. I went from taking my stabilization stuff as part of my workout into my movement prep, into my freaking warm-up. This is the advanced routine, right? So single leg medicine ball lift and chop, which is now, yeah, we're just single leg lift and chop. That's what we call it. So then I need to get something for my left here. Let's go with like, get one more for the glue. Actually, you know what? Let's do toy soldiers. All right, so that's that straight leg kicking march, Frankenstein walk, whatever you want to call it. Let's go with arm circles. And lastly, let's go with, I wish Eddie were here. What the frick is that called? A pike push-up to upward dog. Gah. You know what? We'll just do inchworms. Inchworms, by the way, that's this exercise here. Oh, nope, that's going to pull up pictures of moths. Are you walking out? There we go. That'll get them nice and warm in all the hamstrings and stuff. So we're gonna do 2 sets of all. Oh, how do I know how many sets and reps to do? Those are my dynamic stretches. 3 to 10 exercises. We picked 1, 2, 3, 4, 5. So we're right in the middle. 1 to 2 sets. So we're gonna go with 2 sets, and we're gonna do 10 to 15 repetitions. Let's go with 10 reps each. Just 10 reps there on that last one. Pretty good circuit to get me nice and warmed up. Now I need a, this is where it's going to get sort of complicated. So what I'm going to do is I'm actually going to get rid of the core balance and reactive stuff here from this section, right? We'll come back to it in a little bit. We're going to do it on our SAQ/cardio days. So I'm going to leave core balance and reactive empty there. And we're just going to go into the resistance training. And the reason we're doing that is obviously we need this stuff in our routine. But you look at like the resistance like side of things, notice how it's 3 to 5 sets at a freaking 1 to 2 minutes between, 3 to 5 minutes between circuits. That's a very long rest period there. So we're going to keep these same movements, right? We're just going to kind of shuffle them around a little bit. We're going to have chest day, chest and shoulder day, leg and back, leg day, and back day. So for chest and shoulder day, we need to have a superset here. So we're going to say medicine, ball, chest, pass, right? I'm going to delete all this. So these are the same exercise. That way my client's actually getting pretty familiar with these things. Medicine ball, chest pass. For the military press, we'll go with a push press, dumbbell push press. It's going to be very explosive. For the incline chest press, we're going to pair that up with clap. Deep incline clap push-ups. Actually, no, he's a freaking football player. Clap push-ups. And then for the dumbbell lateral raise, we'll pair that up with it's explosive here. It's actually a tough one. Medicine ball reverse throw. So that's actually going to go up overhead like so, into a wall, you turn around. So that's a lot of work to do in one workout, especially when we look at over here, 3 to 5 sets, 1 to 5 reps for my strength movement. So let's go with 4 sets on all of these. 1 to 5 repetitions for all of our strength movements, 8 to 10 repetitions for all of our power movements. Actually, no, I'm not gonna do that. I'm just gonna pick 10. Right? Tempo is X, X, X each time. 0 seconds of rest after the first exercise, 3 minutes of rest after the second one. This workout is freaking lengthy. 4 times 3, that's 12 minutes of rest. There is 48 minutes of rest in this routine. But remember, they're working as explosively and as hard as possible. So they're gonna need it. So that is workout A. Let's create workout B here. Thanks for sticking with me, guys. I know this is extra long today, but it's the end of the year. We're almost to Christmas break. So workout B, this is going to be, let's say, leg day, right? So I'm going to keep my same warm up, and now I'm just going to change my bench press. I'm going to change this to a barbell squat, just like last time, right? I had all that leg stuff in there. I'm going to go with a deadlift. Let's go with a step up. And let's go, we'll get a little lateral movement here. X band lateral walk. Okay. Which means actually can't really do that for heavy strength. You know what? No, I still really like it. Okay, so for the barbell squat, we're going to pair that up with a box jump. Actually, no, we're going to pair that up with a depth jump. That's my favorite. For the deadlift, we're going to pair that up with a kettlebell swing. Okay. For the step up, we're going to pair that up with power step up. That pairs really well together. For the X-band lateral walk, we're pairing that up with ice skaters. So we're picking the same muscles here. This is actually probably a little bit too much work. Oh, wait, no. Let's see here. How many sets is this? 4, 8, 12. Yeah, 16. We're perfect. So, so barbell squat into a depth jump, right? Heavy deadlift into kettlebell swing. Step up to power step up, right? And then X-band walk, really big, powerful, like lateral movements into an ice skater. So you see how we use the same muscles, we paired them up, right? That's the whole idea here. 0 seconds after the first movement, and then an explosive movement afterwards. That would be 10 each on that, and 10 each on that, actually. All right, so now we got upper back. extension, which is the biggest pain in the butt. This one is actually legitimately very difficult. Upper back power exercises are kind of hard to come by in a way that is convenient. But this is workout C. This is going to be for the upper back, right? So we went with we had the barbell bent over row. We're going to pair that with what's called a pendlay row. It's not in your books. A pendlay row is a barbell row that you actually slam the barbell back down. So you're in a really low position here. You pull it and drop it back onto the ground. It is super loud and universally hated by every normal gym. And you should never do it in like a corporate gym. But if you got bounce plates, you got bumper plates like the rubber ones, go for it. You'll be fine. Instead of this, we're going to go with those weighted pull-ups again. And we're going to pair that with a medicine slam. And now, honestly, we are at, we're getting a pretty good amount of upper back work here. I'm actually only going to pick a third exercise. This is just going to be a slightly shorter workout. Otherwise, we're ending up in sort of the overtraining approach, which we really don't want to do. So for the last one, for my upper back exercise, let's go with let's go with the seated row. And we'll pair that up. So that's a seated row just on the machine there. And we will pair that up with cable face. Actually, cable face pulls. Okay, so go with cable face pulls there. So you can get on the cable machine relatively explosively, very explosive. You can do that with resistance bands as well, but I'm trying to keep resistance bands out of this routine. And there we go, right? I could, by the way, throw like one other like shoulder exercise in here or something. I could do like, in fact, you know what? Just for the sake of symmetry, we will. Yeah, we'll do a dumbbell reverse fly, and we'll pair that up with dumbbell bent over Y fly. Oh, you know what? Never mind. Hold on. I got a better one. Hold on. What? Trying to remember the name. I'm actually forgetting the name of this freaking exercise. What's that? Freaking T-bar row. God. So use the T-bar row, the wide grip attachment. And we will pair that with a TRX power pull. That is a really explosive upper back movement. So the TRX allows you to do a power pull. It's where you're on one side, you reach up and pull like this. Super explosive, really, really good, eccentric and concentric. Upper back power, guys, is probably the hardest routines you've got to build, just because it's difficult to come by upper back power exercises due to the fact that like when you throw something like this, you're going to slam it into your face. So there just aren't as many explosive movements. That's why they're, I honestly, these are like the four that I always use. So that's our workout C. Now, for our cardio bit here, we are going to have a stage 1 day. So we are very much just going to copy this. What is this? Oh, I don't need this. Delete this. So this is stage 3 cardio, but this is day 1, right? So I'm still just going to do some speed stuff and 20 minutes on a treadmill. Nothing crazy there, right? For my day 2, and because I'm taking 60 seconds of rest every time. That's gentle cardio. For my day 2, it's still stage 3, right? But I'm in phase. I need to change this to phase 5. I do that on all of them. Yeah. So there's phase 5, right? And for phase 5 here as well, I'm gonna keep it the same, right? A little bit of speed and agility work, and a little bit of cardiovascular conditioning. And then for day 3, I'm not going to do any treadmill work. I'm actually going to get rid of this because this is going to be where I get some speed and some agility and some quickness in. And this is also where I'll get my movement prep in for the week. We'll come back to that in just a moment. So over here, and I'm going to do a modified box drill. And with the T drill, so now they're going to do a T drill with a medicine ball catch. So what's going to happen is they're going to do the classic T drill, which is that sprint, side shuffle, side shuffle, side shuffle, back pedal. But when they get to the ends of the T's, so they're going to sprint, they're going to come over to the T, they're going to get a pass, they're going to catch it and throw it away. They're going to side shuffle to the side, catch it, throw it away, and then they're going to back pedal. Modified box drill, they don't know where they're going, right? So we look at my SIQ rules, 3 to 5 sets of 3 to 5 reps, explosive tempo, right? So let's go with 4 sets here of 5 reps. XXX tempo. And then 0 to 90 seconds of rest. We will give them 90 seconds of rest at the end of this entire circuit. That will feel, and you guys will believe me when we do this tomorrow, like stage 3 cardio. If their heart rate is not ready to blow up by the end of this, I don't know what will. Now, I do need to do a movement prep section for this same client. So we got to get our movement prep somewhere in the week. We're going to put it right here. And we're going to choose, when we go to our core stuff, we're going to choose core power, balance power, and plyometric power. So a medicine ball pullover throw, a medicine ball oblique throw, not oblique throw. I mean, that would actually work, but let's go with a rotation chest pass. So now, right, they got that, they're on the stability ball and they go back, throw it, right? They're doing crunches explosively. They're doing an oblique throw explosively, right? For our balance power exercise, we're going to do a single leg box jump up to stabilization. So from one leg onto one leg, and they're going to stabilize and hold. And then for reactive power, we are going to go depth jump to bounding. One of my favorites. So we go here, 2 to 3 sets, 8 to 12 reps for everything. So let's keep it at 3 sets here. 12 reps, 12 each, 12. And I mean, honestly, it's like 1 plus 12. You know, for the bounding, it's like, yeah, they'll do 12 steps, like 1, 2, 3, you know, but it's like one big depth jump and then into the rest. XXX tempo, literally for all of them, except for that balance exercise. That's 3 to 5 seconds hold on land. So that's actually the same as our, well, I don't have it on here, but our stabilization exercise, right? And again, 0 seconds of rest for each of these, 60 seconds of rest at the end. So that's our stage 3, cardio routine that we would do on Thursdays. Oh, I just realized I forgot to hold on. So that was, and we'll save this one as power. So now we've got these 3 workouts right here. We got a stabilization routine, strength, and power. And it goes with our annual plan right here. So so this was workout A was that total body routine, stage 1 cardio, and then we just rinsed and repeated all month. The next month, we had the workout A, which was like chest and shoulders, the workout B, which was back and legs, and then we had a stage 1 cardio day on Wednesday. We repeated chest, shoulders, back, legs, and then stage 2 cardio day on Saturdays, right? Where we're getting a little bit of SAQ, a little bit of speed and agility, right? And then month 3, chest day, leg day, back day, stage 1, stage 2, stage 3 cardio plus movement prep day falls on Saturdays. And that is, I mean, honestly, you could do a year of that, and you would still be changing it up just enough that you would get a lot of variety in there. So that took a lot longer than I thought it would. I very much appreciate you guys sticking with me today. Any questions on why we did what we did?
So you did most of this, right? Based on what they wanted to achieve. So this is a football player. So you said, all right, cool. This football player, well, what does he need to focus on? Well, balance, number 1, that's for sure, because he needs to be quick on his feet, for sure. He needs to be able to be able to stick and move. So we put him on balance. Then you realize, well, usually they want to be big and strong, right? Hypertrophy. Then they want to be explosive. So we take him to stage 5. And because he's already been playing football, we don't need to take him through the whole OPT, right? Usually that's just for people coming in, right? That start off.
For the record, with an actual football player, I would want some endurance. So I'd probably do a little bit of strength endurance training at some point during the year. Right. This is a very, very, very simplified program.
Okay.
And then max strength is huge, So like the hypertrophy that we did was around 6 reps. That's just over the line from max strength to hypertrophy, They're really similar to one another, but they're just not quite exactly the same. But we got as close to max strength as we could. I would say, like, for an actual football player, all 5 phases of the OPT model would work really well. But imagine if we had to build 5 phases today, you guys would be here till midnight.
Okay. But for the most part, it's just based on what he wants to achieve, right? And then you just build around that. Exactly. Mostly, right? Mostly.
Yeah. And then remember, we took his sport,
right?
We paired it, and then every workout I remembered, what has he got? He's got an anterior pelvic tilt and he's got his arms falling forward. So we kept working all year on just loosening up those muscles. Now, you will also notice I kept the warm-ups the same, consistently every workout. I'd probably swap things in and out so they get some variety in there. We kept a lot of similarities between them. I picked the same speed ladder exercises from month to month. We kept stuff very, very simplified. This is meant to kind of show you the principles behind things. I would probably change things up a little bit more than this just to get some variety in there. I wouldn't do 1-ins on that speed ladder for 3 straight months. Right. I'd probably do some variation.
Okay.
But still,
it was just to give us the groundwork, right? Just
yes,
give us the groundwork.
Exactly. You guys should notice when you look at this routine, and I'm going to email it to us. And I'll put this in Canvas as well. You should notice when you look at this routine that the main thing I want you guys to take away, especially like my new folks, we followed all of these rules.
Right.
And It applied physiology and the principle of specificity really, really well. We got the principle of variation, we got the principle of specificity, the principle of individual differences. We got everything covered with a routine like this in its most basic, simple form that I could do in, 30 minutes.
Right. So it's like, okay, so you just took, so you pretty much you built it because he's a football player, but you also took into consideration that his arms fall forward. So you're like, all right, we need to loosen those up.
Every client.
All right, cool. Yeah, no, I get you.
Always. Yeah. Edwin, Joseph, how you guys feeling?
Good. My only question is because you just randomly going off exercises, but these are all the exercises on that list you sent us, right?
They
Or
sure are. Yeah, that's one thing for my new folks, and honestly for everybody out here. If you're not super familiar with that list of exercises, like the pen lay row is the only one today, I think, that I picked that wasn't in your book. Every one of those exercises is either in the sports book or in your regular.
Okay.
And those are all the NASA names for them as well. Honestly, I don't call most of them that. Oh, face pulls is also not in your book. But it's a great exercise. There's a couple that I picked the very common sort of standard names for everything. They should be very easy to Google.
Yeah, I just want to make sure because like, wait, where's he getting these exercises from? And then I remember you sent us a list.
Yeah,
I'm like,
totally. But remember, again, go back to exercise selection. On the stabilization day, I picked resist. They're in the stabilization list. For the hypertrophy day, they're in the strength list. For the power day, they're in the power list.
Okay.
Plus
Yeah,
the
I was like, where's he getting these from?
Yeah, they're in there. Yeah, that is confusing. Thomas, how you feeling?
I'm feeling fine.
Yeah. This is your last, dude. This is your last lecture with me.
Yeah.
I mean, we got the in-person tomorrow, but and we got the review on Thursday, but still.
Right.
All right. Well, guys, if there's no questions, let's kill this recording here. How do I always forget how to do this?